Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by ACAP Strategic Ally Pop Healthcare and MCARA Health. Our presenters today are Carol McLean, Vice President, Market Operations with MCARA, and Robert Kraus, Medical Director with Banner Health Long-Term Care. They will be presenting the webinar, Telehealth is not enough when it comes to caring for vulnerable populations. But before I turn it over, I have a few housekeeping items I need to take care of. This call, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's webinar, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking the Q&A icon in your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Carol and Robert.
Thank you, Ron. Good morning, everybody, or good afternoon, depending on where you're located. My name is Carol McLean. I am the Vice President of Market Operations for MCARA Health, which is part of Pop Healthcare. I'm here in Phoenix, Arizona, where it is going to be 100 degrees today. And I'm very happy to be joined today by Dr. Robert Kraus, who's the Medical Director for Banner Health Long-Term Care. Banner Health is a nonprofit health system based here in Phoenix. It operates 30 hospitals, several specialized facilities across 6 states. The health system is the largest employer here in Arizona and one of the largest in the United States with over 50,000 employees. Banner also operates a Medicare Advantage insurance plan, as well as a managed Medicaid and LTSS plan in Arizona. So today we are going to be speaking about vulnerable populations and the role of the telehealth solution in caring for them. By the end of the discussion, we will have covered a few key areas: the demographics of these vulnerable populations and telehealth use, barriers to successful deployment of telehealth-only programs within these populations, and some real-life examples and lessons learned on how to leverage telehealth modalities to bolster in-person care, especially for those who require home-based care. We hope to make this session interactive, so please feel free to add your own experiences and any questions to the chat box. Before we begin, I'd like to very quickly familiarize you with MCARA Health. We are a value-based medical provider delivering high-touch in-home primary care to complex members who reside in private homes, in assisted living homes and centers, as well as long-term care and nursing homes. We recently rebranded all member-facing care delivery under the MCARA Health brand as part of our national medical group, but Pop Healthcare has been delivering home-based primary care for nearly 9 years. While many providers have been utilizing some form of telehealth, including MCARA, as an adjunct delivery model for many years, it suddenly became the default care delivery model for the majority of primary care visits during the pandemic. While this certainly provided us with a much needed modality to ensure continuity of care, it has also given us an opportunity to review its impact on the current disparities of healthcare access among vulnerable populations. A quick review of some of the demographic factors of vulnerable populations that have implications for telehealth usage. 50% of Medicare Advantage beneficiaries live below the federal poverty level. In 2022, that was approximately $36,000 for a family of 2. 30% of Medicare Advantage beneficiaries and 26% of fee-for-service members experience some type of social determinant that negatively impacts their health, food insecurity would be an example of one of those. A significant portion of our Medicare Advantage population experience poverty and the social barriers that are associated with poverty. 1/4 of the US rural population is covered by Medicaid. Two of the largest groups covered under Medicaid are Black and Latino. These represent people in a population who are already generally underserved and who may face numerous barriers to care access. 55% of Medicaid and dual eligible populations live below 100% of the federal poverty level, around $27,750 for a family of 4 in 2022. The same limitations exist in these populations. In reviewing the statistics related to telehealth usage during the pandemic for these populations, it was noted that 1 in 4 Medicare beneficiaries used telehealth during the pandemic. However, 56% of those were audio only, no video component. Those without a high school diploma was about 38.1%, adults 65 and over, 43.5%, and Latino and Blacks around low 50%. Across all populations, video telehealth rates are lowest among these groups. Per a 2020 JAMA study, patients who scheduled telehealth visits but did not complete them was highest among people age 55 and over, Medicaid beneficiaries, and non-English preference patients. Based on these statistics, it appears that the wide-scale implementation of telehealth does increase the disparity in access for care for vulnerable populations. Unfortunately, factors such as poverty, ethnicity, living in rural areas, and even some urban areas impact how and even if individuals can participate in care delivery via telehealth. About 30% of all US rural residents don't have access to broadband. Americans with disabilities are significantly less likely to have desktops, laptops, smartphones, and home broadband needed to support telehealth. Only 64% of people age 65 and up report having broadband at home. About 1/3 of the 32 million Americans who cannot use a computer are seniors. I know me myself, when I roll into a problem with my computer, I call my 9-year-old grandson. Digital literacy is a greater barrier for older people, minorities, low-income individuals, and rural populations. Inadequate digital literacy is not only a barrier for patients, but also for some health professionals who are tasked with utilizing this technology. Banner Health manages a large LTSS population that relied heavily on telehealth during the height of the pandemic. I will now turn it over to Dr. Kraus to provide some characteristics on that membership.
Thank you, Carol. Banner Health has a health plan that consists of acute care as well as long-term care, and our overall population is over 300,000. But only there are about 6,000 long-term care, as we refer to them as, or LTSS members. Of that, the objective of these LTSS members is to have them reside in a surrounding that is as close to home as possible. And of those, we have at least 70 to 75% are living either home or in assisted living facility. The remaining 20-25% are living in skilled nursing facilities. Our long-term population is such, based upon, you have the details as to how the determination for qualification is financially. The population distribution is interestingly in the mid-zone between 60 and 79, 53%. And then the distribution of ethnic distribution is approximately 40% white, 35% Hispanic, and 10% African American, with remaining Asians 10% and others 5%. So we have a diverse group, and this group are highly vulnerable. 50% of this population are dual members, meaning they have Medicare as well as Medicaid. And it becomes somewhat difficult in management because of the two resources, so that case management is even more complicated. With regard to telehealth, in the skilled nursing facilities, without the ability to have visitations, it was quite helpful. As in general, virtual visits were helpful, but nothing can compare to on-site visits, which is what our population really thrives on. Our case managers, for those that are residing in either ALFs or in home, are reviewed by the case managers every 3 months. So they develop a very close relationship with them. And for those that are living in SNFs, it's every 6 months that the case managers will review. We use Pop Health to attend to many of our members who are either in assisted living facilities or skilled nursing facilities, the majority of which are those that are living either home or in assisted living facilities that are attended to by Pop Health. As you can see, chronic diagnoses, the preponderance involves a lot of pulmonary COPD, diabetes with all of its complications, including wound issues, major depression, and behavioral health issues plague many of our members as well. The other diseases include any pulmonary or cardiovascular diseases.
Thank you. So between March 30th and May 15th of 2020, the state of Arizona was under a statewide lockdown due to the pandemic. During that time, MCARA Health quickly diverted to telehealth visits for all of our banner patients. I'd like to share some of the lessons that we learned during that period, and I'm sure many of these are probably familiar, with you as well. So before we talk about some of the things that didn't work, I'd like to just take a minute to talk about, the things that did work. So, one of the main positives for using telehealth during this time was really that continuity of care. Patients really appreciated that they were still provided access to their providers during this time. These are the people that, are used to them, that understand their environmental access, that understand their family situations, that understand their social barriers. And that didn't really have to stop. We just had to use a different modality. They also appreciated that we were certainly concerned about their safety, which is why we were not going into their homes during this period. They also kind of stated things like, oh, well, it was kind of nice that I didn't have to clean up for your visit, or, get things ready around the house, or relocate the dog. So, certainly some advantages to using the telehealth modality, especially during this time period. One area that we quickly kind of learned was going to be a challenge was those members who were in assisted living home centers and long-term care facilities. So, as you recall, these were the locations that were the hardest hit by the pandemic. So certainly they had staff that was overworked, and sometimes, they were low staff. So utilizing telehealth with facility patients who didn't have a personal phone that they could do kind of on their own, quickly became unrealistic. So certainly we couldn't rely on the staff to, help these patients get connected to telehealth or hold the phone so that we could do the telehealth visit. So, we really had to rely more on telephonic or audio, and really just using the facility staff to be our eyes and ears during that time period. So definitely saw, a big difference with using telehealth within those facilities. Many of our patients are fortunate enough to have state issued mobile phones under their plans here in Arizona. Generally, those phones have limited capabilities, certainly not all the bells and whistles that everybody is used to on their smartphones. Some did not have camera access, and those that did had no idea how to use it. We kind of laugh a little bit because, kind of some of those initial, use your camera, we saw a lot of fingers, toes, and cheeks, a lot of cheeks, because they were put their camera on and then of course put it up to their ear and we would see their cheeks. But so kind of what kind of access they had from a phone perspective, certainly varied. Some of our patients do live in areas with limited internet access. You probably know about those. Those are the ones where you have to stand in only one room of the house on your left leg and hold your right arm out. We do have patients that, certainly live in settings like that. Certainly using telehealth became more difficult when you had, internet connectivity issues. We also, no surprise, recognize that many of our patients are not tech savvy. So really struggled not only with just how to utilize their phone, but then how to use our telehealth platform, which required, multiple clicks here and there and going onto a URL and doing some different things. The other thing that we found was that it was not only our patients that sometimes were not tech savvy, it was our providers. So, a lot of our providers are a little bit older, they're kind of old school, came from, where you did paper documentation. The most we're able to get them to do is an EMR. So, adding this additional modality was sometimes a challenge for them. And one of the big examples, kind of from this tech savviness was our particular telehealth platform used Chrome as the browser. So just explaining to someone who really doesn't understand what a browser is, but the difference between Chrome and Explorer really was a learning curve. So found that to be really, really interesting. And then even if a patient did have, the right technology, internet access, had the right browser, we have a lot of patients that either have eyesight issues, they may have some mild or moderate cognitive impairment, which also further complicated their ability to utilize, understand the telehealth application, even if everything else was in place. We did recognize that once the lockdown was lifted, we quickly got our providers back out into the field. As Dr. Krause alluded, we know that is the best way to do these visits with these vulnerable populations, is to be in the homes, accessing the environment, really developing a great therapeutic relationship, spending the time with these patients. We knew that that was something that we needed to do as soon as it was really safe to do that. But there was only a limited number of patients that actually asked us to continue telehealth for their primary visit. And that was really just from an ongoing safety, like I'm just more comfortable if we do this via telehealth. And then about 6 months later, telehealth really returned to pre-pandemic levels, which for MCARA really was limited use for in-between visits. We are not using it hardly at all for, kind of our general visits or routine visits. Most people really do want that in-person experience. So I'm going to turn it back over to Dr. Krause. I know he has his own personal experiences during this time.
I do, and I still laugh about it. As an obstetrician trained many years ago and practiced for many years, I had the ability to really develop close relationships with my patients, and there was my instructor was an incredible human being, and the first thing I learned from him was when he went to the bedside, the first thing he would do would be to put his hand and check somebody's pulse. And we all acknowledged, why is Dr. Jennett doing that? And the response was, part of it was to just calm down the patient and just that reassurance. And so that was a big part of my practice, the communication aspect of it, because that really was an entree to exceptional communications. The downside of being an obstetrician was that 2 and 3 o'clock in the mornings, I had many deliveries, And so I wish that there was some sort of telehealth opportunity from that regard. That would have saved a lot of sleep on my part. But there was nothing like that direct communication. My personal story is that I had an appointment scheduled toward the end of the highest phase of COVID, so that it was still not unreasonable to go to the doctor's office. And they asked me specifically, would you like to have a in-person visit or a virtual? And I said, no, I'd like to come to the office. And so it was scheduled, and the day of the appointment, I appeared at the office 1 hour too early. And so they advised me of that after I had signed in. And I said, well, I'll go ahead and do some errands. I'll come back in about an hour. So I came back to the office in about an hour, and at which time signed in again, and they handed me an iPad, and they said, go to this examining room. So I took it into the examining room, and quickly on the iPad, within 5 to 10 minutes of sitting there, I got communicated with a person who I thought was in the office. Essentially, she asked me how much I weighed and asked me what my blood pressure was. And I thought, well, this is odd. I'm standing in the office, and my expectation would be at least I'd be weighed and blood pressure check and general discussion. And she asked me some more questions about medications and such. And she says, well, if you'll hold, the doctor will be with you shortly. And so, of course, expecting to see my doctor in the next few minutes, sat there another 10 minutes, and 10 minutes later on the iPad was my doctor. Well, where was my doctor? He was at home while I was sitting in his examining room. So I thought, this is the end all of this virtual visiting. But really, I think that we can't throw away the concept, because it is very functional. It has some very positives. I remember when I was first exposed to it several years ago, it was used in rural areas, and in particular, it was used by some clinics whereby there would be maybe a PA or a nurse who would communicate with a doctor for an orthopedic clinic. So there might be 3 or 4 patients there that the doctor could consult with, while the nurse helped with the exam and with the histories. So it does have its place, but I think that it should not be abused. And I think COVID really helped to put it on the map. It was used also initially for behavioral health, and what we've seen in the health plan in particular for our younger members was that it was more satisfactory, because it didn't take them away from some of their normal activities that they were involved with school, sports activities, and everything else. So there is a place for it, but it shouldn't be abused, and there certainly is no substitute for face-on. For continuity of care, it can be helpful, so that for follow-up visits, it can be very helpful to assure that there's been compliance with medications, and in general, it has its usage. But as I say, hopefully it will not be overused, and I think we've already seen from the use by Pop Health, they're back to face-to-face, which is the ideal way to see people.
Absolutely. Thank you, Dr. Kraus. So kind of in spite of certainly some existing barriers, telehealth can certainly be deployed in ways that help to bridge barriers and disparities. So some of the ways that, we kind of look at, kind of helping with some of the transition is start by just understanding that there are limitations in digital literacy and access for this particular population. One of the things that we're looking to do, we do SDOH assessments on all of our patients, and really adding that as one of the questions that we ask is, what is their digital literacy? Do they have access to, any kind of a smartphone, or access to, not only for telehealth, but telemedicine? So, what are the barriers there? Make sure that you're providing patients with information about reduced cost or free broadband internet in areas where it's offered. I know that that's something that, the government is certainly looking to expand, but sometimes it takes some digging to really find out, where that's available and how to access it. We are fortunate enough on our team to utilize community health workers So one of the things that, we started doing after kind of the lockdown is in areas where, we could offer a community health worker to actually go to the home of the patient that wanted to do a telehealth visit and really be the one to kind of get it all set up. And that kind of took that frustration away from the patient. You had somebody that was in the home that was really setting it all up. Obviously, there's other like type roles that, have that patient connection that can really help with some of those kinds of things. Implementing user-friendly telehealth platforms. Again, I think for a lot of us, while we had telehealth technology available to us, we really weren't using it on any kind of a broadband scale. I know, for ours, while some people thought it was easy to use, there were a lot of clicks that had to happen and URLs and, things to navigate kind of through the application. And I know some of our patients said, well, why can't I just do FaceTime? I mean, it's easy. You click a button and that's it. So, really looking at whatever your telehealth platform is and making sure that it's very, very user friendly. Calling the patient a day or two prior to the scheduled visit just to set up and practice. We did this, quite a bit kind of during that time period where we really had to rely on it. And I do think we had some good success with that. At least it helped us identify where the barriers were, and gave us time to explain what a browser was. So, we were really able to kind of work through some of the kinks, I think, by kind of giving a few more days to getting set up. But wrapping up, as an adjunct to in-person visits, telehealth definitely, as a model of delivery, has a place in our healthcare system. I think there's no doubt about that. For vulnerable patients, however, there's still a great deal of work to do and probably some more studies and some more education to ensure that telehealth does not exacerbate what we already have as some health disparities. So that is the end of our presentation. Be happy to entertain any questions that anybody has.
Okay, our first question today. If we don't have a community health worker program, what are your recommendations for making it easier for vulnerable populations to use telehealth?
Well, my first recommendation is get community health workers because they're amazing to work with. But I certainly understand that not everybody has, the access to, that type of role. And then I think it's really just going back to, some of the other things that I mentioned, doing the practice test ahead of time, making sure that they have the tools that they need to be successful with telehealth, will really help improve their experience. Good question. Thank you.
Okay, our next question. Sometimes the people who make decisions about telehealth and how to use it don't necessarily understand all the barriers you've talked about in your webinar. Do you have any recommendations for how to get them to see the realities of the population we are working with?
I'm going to punt that one to you, Dr. Kraus.
Well, obviously, ongoing education, such as we're doing today, getting the word out with regard to, our particular program. I think we have such great communication with our members through our case managers, and they have an understanding, and they can communicate, and they do communicate these specific issues. So it does go up the ladder, and they're well aware of the disparities that are existent. Some of the things that they try to do are getting agencies to support, maybe getting phones for members. Those are the kinds of things, and introducing or getting some assistance from family members. Usually, if there's a grandchild or someone who has had familiarity, such as Carol has explained about her grandson helping her with a computer, getting that kind of assistance. And also, peers can be very helpful. So using every aspect of relationships that you can have with regard to every aspect of education amongst our members, because if we look back 5 years ago, we could never have done the things that we did do during this pandemic. So things do move very quickly. Technology moves very quickly. I remember years ago when my dad, he didn't have a computer, but he had one that was kind of geared through the television. So he had this extra little box and he was doing, quote, computer work, and he was at that time in his late 80s. So you can always teach an old dog new tricks as far as I'm concerned. So it's education, communication, and letting the people that are in control of these things learn more about these disparities so that we can clear them out.
Okay, well, that looks like it takes care of our questions for today. With that, I'd like to thank all the attendees for taking time out of their schedule to join us today. I'd also like to thank Carol and Robert for a very informative webinar. I'd like to also remind everyone that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks a lot and stay safe.
Thank you.
Thank you.
Bye-bye.
Bye.